It's so tempting to talk about what went wrong. We do it all the time. We try to dissect our mistakes. We try to prevent them from ever happening again. But what if something goes right? Really, really right. Perhaps then we might even learn a little bit more. So that's the story of early elective delivery, EED. And when we implemented it in the early 2010s, how it worked, and what can we learn when other innovations and other implementations did so much to struggle? Hi, I'm Bruce Spurlock, a physician and healthcare leader, committed to helping leaders and decision makers navigate change with clarity. On viral healthcare, we look at the trends spreading across healthcare, what it takes to implement them wisely, effectively, and sustainably. So let me give you a little bit of background on early elective delivery, EED. This was a practice that started many, many years ago. This was when physicians and women would choose the date that they want to deliver their baby. There might be a day they were trying to avoid or a day they were trying to actually target for personal reasons, for preferences, for lucky numbers, for the aunt or somebody who meant so much to them that they wanted to have their baby on that date. It started off as relatively harmless, people thought, just picking the date rather than going through a natural labor when you might actually have to have a C-section if you had complications. Why not plan the date out and have it when you want it on your preferences? It turns out the evidence didn't really support that. Babies that were born prematurely, electively, before 39 weeks of gestation were going to the NICU, the neonatal intensive care unit, much more frequently. So there became an effort to stop it. And it's interesting, the first work from the American College of Obstetrics and Gynecology, the professional association dealing with maternal care, suggested well back in the 1990s that we probably shouldn't be doing this. This is harmful and not a good idea for babies and moms. But it really wasn't until 2010 that we actually looked at it in a much more meaningful way and thought about how to reduce it. By that time, it was almost 1 in 5 babies were being born electively, that is without a medical indication, before 39 weeks of gestation. So what did we learn during that process? It only took 3 years. We went from like 17, 18% nationally to well under 5% nationally in 3 years, starting in 2010, 2011. And how was it that this swept across the entire country? Well, the first thing we learned was that it had been around for like 15, 20 years, that the evidence suggested we shouldn't be doing this. But for whatever reason, that just wasn't going on. And when we look at other interventions across healthcare, evidence alone is not enough. It's necessary, but not sufficient. The second thing we learned is that you actually have to redesign the system, that just educating, just inspiring, just persuading the healthcare system, whether it's docs, nurses, administrators, anybody else, it's not enough. What happened was we implemented a hard stop. We redesigned the system so that every time a baby with less than 39 weeks gestation came up for delivery, before that delivery could be scheduled electively, it had to make sure that it was after 39 weeks or it was stopped, and the physician had to meet to prove while it was medically necessary. The third thing that happened was we got alignment across all the stakeholders, insurers, regulators, patients, all the different important hospitals, all the important stakeholders got in alignment, and that was really well designed. And finally, we had these large national and statewide learning collaboratives to spread implementation techniques, like what does leadership have to do to make sure they've got the backs of the people who are actually trying to implement this? How can we convince them that the doc is just not going to take their deliveries down to the hospital down the street? All of these things kind of work together. It wasn't one single intervention, something in healthcare we try to do often. Let's look for the magic bullet. It was a simple intervention, but it was really important that we had that leadership backup, that alignment through all the different stakeholders, and just sort of the national will that we could make it happen. It's kind of putting wraparound services in a synergistic activity to support that whole effort. So here's the question when you're thinking about implementing a new intervention. Are we just providing education and persuasion? Or maybe we're just using evidence, thinking that's going to do it. Or do we need to redesign the system? Can we engage with other stakeholders? So it's more than just our organization or our field. It's really much broader and much bigger because it'll go faster. It'll be much more likely to be successful and spread much more quickly if you do that. So these are the kind of few things that I wanted to do on this reflection about this week's podcast. And if you're implementing a new idea, a new intervention, a platform, just think about what difference you might make if you were to ask and answer these questions. So if you're in that position and you're interested in learning more about it, join us on Tuesdays and Fridays as we discuss new ideas and how to implement them effectively and sustainably, and whether we should be implementing them at all. Thanks a lot for listening to Viral Healthcare. I'm Bruce Spurlock, and I'll see you next time.